Hello everyone, this is Arch 2023. I'm really privileged today to be with Dr. J. Mathews, who is a pioneer in VTE and coronary thrombectomy. Jay, thanks for being with us.
Appreciate it, thank you so much.
You are one of the chairs for committee planning for the peripheral track, and there's a lot of advancement in thrombectomy, arterial and venous.
Yeah.
So tell us a little bit about recent advancements.
Yeah, so there's a lot of exciting stuff going on right now too. We finally got on the coronary side of things, we finally got the Chadi trial published. It's available in CERT Cardiovascular Intervention, so please check that out.
Nice.
And we also announced the Chadi ACS trial, so that's going to be the randomized trial looking at the cataract system for essentially STEMI patients, versus standard care PCI. So hopefully we're going to be able to move the needle on the concept of powered aspiration or continuous or sustained aspiration thrombectomy for high thrombus burden patients, ACS, and show that there is a benefit, because that's what the original Chadi data suggested, and now we really just need to prove that concept in a randomized trial, and hopefully that's the kind of stuff that we need in order to be able to change the guidelines, hopefully from a 2B maybe even to a 2A.
Absolutely.
Again.
That's my question to you. So for operators, the guideline is going to take a few years to come back,
right,
and to change that practice. So for practitioner out there, which patient is the candidate for coronary thrombectomy?
What we did, and Sanjay Jolly, who is the PI of the total trial, which unfortunately the results were negative, higher rate of stroke, and really no difference when it came to doing routine aspiration thrombectomy for patients with a high thrombus burden. So they looked at, they had all comers, but then later on, they looked at the high thrombus burden subset and still found no difference. And some of that was also technology based, because we know that the manual aspiration catheters just are unable to maintain sufficient suction. The orifice is small, they don't track as well. And so for multiple reasons, maybe these technologies were not as good. But it does seem that the cataracts catheter is much more powerful suction, continuous suction, much more trackable. And the myocardial blush grade that was reported in the Chadi trial was incredible. I mean, in terms of, it's almost 100%, 99% MBG3 at the end of PCI cases. High rates of TIMI flow, and really extremely low residual thrombus post cataracts, essentially on average most of the time just with one pass.
Yeah.
So obviously the guidelines will take time to change. People that are using it believe in it, but hopefully now with randomized data, if it's supportive, that will get more people to want to be able to use this, because it is, it's an FDA-approved device and it's available, and I think that it can be very beneficial potentially for those patients with high thrombus.
High thrombus. So when you say high thrombus, means TIMI 0 flow or TIMI 1 flow is with it?
I mean, so typically what we use is the TIMI thrombus scale. So grade 4 or 5 thrombus. So if you see something that's at least the length, if you have a diameter of a coronary vessel greater than 2 lengths of that diameter, that's at least grade 4 or 5, essentially total occlusion.
Exactly.
So we see a lot of STEMI patients with those types of cases. So post wire crossing, a lot of times the wire will break it apart and you got flow. So in those kind of cases, perhaps you don't need to do it. But many of us still believe in this, and we don't like the idea of distal embolization, which was reported as high as 40% in some of the historical trials, or rather 15%, and then in our trial it was only 0.75%. And then
it's technology, technique.
Absolutely. So essentially you engage coaxially with your guide catheter. You turn on aspiration the moment you exit the guide. You continue all the way down to the occlusion, sit on it for about 20 seconds or so, and then you come out of the body under continuous aspiration until you exit the 2E Bors catheter, and then if you have to do another pass, you flush the catheter first and then you go back in, because sometimes there can be clot in the catheter.
Yeah. So one of the last question is this delaying door-to-balloon time?
It is not. In fact, improving door-to-balloon time. It's not even, we don't even care about door-to-balloon. It's really door-to-reperfusion time, because D2B, nobody cares about what device you use. It's whatever gets you reperfusion. And if you go ahead and inflate a balloon and you still have thrombus there and you have no flow, you're still on the clock.
Yeah.
So the reality is,
the problem, the misunderstanding is, if the balloon is up, that's a balloon time.
Yeah.
It's a misconception.
Yeah, it's a misconception, because if you inflate that balloon and you come down with the balloon and now you have still no flow, you're still on the clock.
Yeah.
So what we've seen is that our reperfusion times have dropped dramatically. And this is something we'll talk about more, hopefully within the randomized trial as well too, and even looking at sub-analyses of Chadi itself. But what we found is that our times dropped dramatically in terms of getting reperfusion. You know, we're talking about even during the day, sometimes 12 minutes, you know? So it's pretty impressive in terms of what we're able to accomplish.
Absolutely. Well, Jay, thanks so much for your time, and congrats for putting this session together and the program Peripheral Track. Please watch these videos and others on Arch YouTube channel. This is Chadi from Arch 2023. Jay, thanks so much.
Thanks a lot, appreciate it.